Namaskar. Today we study classification of anti-diabetic drugs. So as we know, diabetes is a chronic metabolic disorder characterized by hyperglycemia, and hyperglycemia is a condition in which the blood sugar level becomes more than the normal, and the fasting sugar as well as the postprandial sugar increases. So fasting sugar increases more than 7 millimole per liter, whereas postprandial sugar increases more than 11.1 millimole per liter. And so how this hyperglycemia occurs and how it is regulated, and if you see what is the mechanism behind that. So our food mainly consists of carbohydrate, protein and fat, and the carbohydrate are digested to glucose, proteins are digested to amino acids, and fats are digested to the fatty acids. And these are the simpler forms: glucose, amino acid and fatty acid, which are absorbed, they enter the blood circulation, and then they are utilized by our cells in peripheral tissues like liver, muscle, adipose tissue. And when this glucose is not utilized by our cells, then this glucose remains in the blood, and that condition is called hyperglycemia. And the non-carbohydrate sources like amino acid, fatty acids can also be converted to glucose by the process of gluconeogenesis. So diabetes is mainly characterized by hyperglycemia, and hyperglycemia the different regions are the hormone which number one, the hormone which helps in entry of glucose into the cells is called insulin. So if there is insulin deficiency, then there will be hyperglycemia. And another group of gut hormone called incretins, which are secreted in response to food in our GIT. These incretins also play a role in controlling the sugar level. There are two incretins. One is glucagon-like peptide 1, and the other is, so you can write here, glucagon-like peptide 1, and the second is glucose-dependent insulinotropic polypeptide. So glucose dependent insulinotropic polypeptide. So GLP-1 and GIP-1 are the two incretins. GLP-1 acts on the GLP-1 receptor, GIP acts on the GIP receptor, and they are located in hypothalamus, GIT and pancreas. In hypothalamus, they suppress the appetite. In GIT, they delay the gastric emptying. So the food intake decreases, and in pancreas they act on alpha cell as well as beta cells. In alpha cells, they decrease the glucagon secretion, and glucagon actually promotes your increases your glucose level. So by decreasing glucagon, it reduces the blood sugar. And in beta cells, they increase the insulin release. So insulin helps in penetration of glucose into the cell, so the blood sugar level decreases. So in this way, incretins play a role in decreasing blood sugar, and these incretins are degraded by the enzyme dipeptidyl peptidase 4. So incretins are degraded by this enzyme, and if we inhibit this enzyme, then we can increase the level of incretins. We can use GLP-1 receptor agonists, we can use GIP receptor agonists, We can use direct insulin, whether it is from other sources like beef insulin or pork insulin, or nowadays we are using insulin prepared by human recombinant DNA recombinant technology. So we can use that insulin, or we can use drugs which inhibit the digestion of carbohydrates to glucose. So the group of enzymes is called alpha glucosidase. So glucosidase, alpha glucosidase inhibitors also we can use. Then this glucose is stored in liver, muscles as in the form of glycogen, and the process is called glycogenesis. And several enzymes are involved in this process of glycogenesis. So glycogenesis will decrease the glucose level, and the process by which glycogen breaks down to glucose, when there will be deficiency of glucose, so glycogen breaks down to glucose. So that process is called glycogenolysis. So glycogenolysis promotes the blood sugar level, or increases the blood sugar level. Then the free fatty acids, they are uptaken by the adipose tissue, they are uptaken by the muscles, and in the adipose tissue free fatty acids are converted to triglycerides, and this is promoted by another nuclear receptor called PPAR gamma, peroxisome proliferation activated receptor gamma, and that promotes the differentiation of adipocytes from pre-adipocytes to adipocytes. So free fatty acid level is decreased, and free fatty acid, when the free fatty acid levels decrease, that means the competition with glucose to enter into the muscles will also decrease. So by promoting adipogenesis, the free fatty acid levels can be decreased, and that promotion of adipogenesis can be done by PPAR gamma agonists. So free fatty acid levels decrease, so there will be less free fatty acid available to compete with glucose uptake. So it will promote the glucose uptake, and again hyperglycemia will decrease. So these are some of the mechanisms by which our anti-diabetic drugs act. Then finally this blood sugar or glucose is filtered through glomerulus, and though it is filtered through glomerulus by glomerular filtration, but 100% glucose is reabsorbed in the proximal convoluted tubule through the transporter called sodium glucose cotransporter 2. So when there is more sugar level in the blood, that will create a pressure on the kidney, and this 100% reabsorption doesn't occur, and that will cause diabetic kidney. So the pressure on kidney increases, and in normal people, because of 100% reabsorption of glucose, no glucose appears in the urine. But when there is a severe load of glucose on kidney, in that case we can inhibit this reabsorption by using SGLT2 inhibitors. So that will help in the diabetic kidney. So these are all drugs which we can use. So now let us discuss the classification of anti-diabetic drugs. So the drugs can be classified into parenteral and oral. So parenteral, the three group of drugs are there: insulin, amylin mimetics. Amylin is one hormone which is co-secreted with insulin. So amylin mimetics we can use, and GLP-1 receptor agonist we can use. Some GLP-1 receptor agonists which are oral also are available now, but initially they were parenteral. So insulin parenteral is used parenterally, and the route of administration is subcutaneous. So the source wise we can classify them as beef insulin, pork insulin, or human insulin. Human insulin is the DNA recombinant forms of insulin. So they are prepared by DNA recombinant technology. Based on duration of action, we can classify insulin into ultra short acting. Duration of action is 3 to 5 hours, like lispro insulin, insulin aspart. When the duration of action is 5 to 8 hours, short acting insulin, that is regular insulin or soluble crystalline zinc insulin. Then 8 to 12 hours of duration of action, intermediate acting NPH insulin or neutral protamine hexdron and lente insulin. Then long acting insulin's duration of action is 24 hours, and example ultra lente insulin, insulin glargine. And we can have pre-mixed insulins where we can combine regular and NPH insulin in the ratio of 30-70 or 50-50 or 25-75. Then we can have amylin mimetic agent, which is also used parenterally, example pramlintide. And GLP-1 receptor agonists, GLP-1 receptor agonists like exenatide, lixisenatide, liraglutide. And we can have dual GLP-1 and GIP receptor agonists. GLP-1 and GIP receptor agonist just recently approved by FDA, like tirzepatide. Tirzepatide is acting as agonist on both GLP-1 and GIP receptor. Now, oral antidiabetic drugs, we call them as oral hypoglycemic agents. First group, insulin releasers. It includes two groups of drugs, sulfonylureas and meglitinide analogs. Sulfonylureas, first generation and second generation. Now, mostly we use the second generation, and the most commonly used drug nowadays is glimepiride. So first generation drugs can be again divided into short acting, intermediate acting and long acting based on duration of action. Short acting like tolbutamide, intermediate acting like acetohexamide, tolazamide, long acting like chlorpropamide. These drugs are not used nowadays. Second generation again based on duration of action can be classified as short acting glipizide, intermediate acting glyclazide, long acting glibenclamide and glimepiride. So because of its long duration of action, glimepiride is the drug of choice nowadays among the sulfonylureas. And meglitinide analogs like repaglinide, nataglinide has the same mechanism as that of sulfonylureas. These drugs increase the release of insulin from the beta cells of islet of Langerhans of pancreas, so they are useful in type 2 diabetes mellitus. Then some drugs are there which act by reducing the hepatic glucose output. So glycogenolysis, gluconeogenesis are the mechanism by which liver produces glucose, so that is called hepatic glucose output. That can be reduced by promoting glycogenesis, inhibiting glycogenolysis and inhibiting gluconeogenesis, that is from non-carbohydrate sources, formation of glucose, gluconeogenesis. So all these things are done by biguanides. So biguanides like metformin, fenformin, and they also enhance the insulin effects. So some insulin sensitizer action is also there. Then the third group of drugs increase the insulin sensitivity. They can be used in insulin resistance, and they are PPAR gamma receptor agonists. So they are called as insulin sensitizers because they increase the insulin sensitivity. The drugs are called thiazolidinediones or glitazones. Cyglitazone is the first drug. Pyglitazone, rosiglitazone, N-glitazone, troglitazone are the other drugs. And drugs like rosiglitazone are recently banned because of their toxicity. Then the fourth group of drugs is drugs interfering glucose absorption. So by alpha glucosidase inhibitors are there, and they inhibit the digestion of carbohydrates, and we can use alpha glucosidase inhibitors and sucrase inhibitors. See, this voglibose is also a sucrase inhibitor. Sucrase is the enzyme which converts the disaccharide sucrose to glucose. So sucrase inhibitor voglibose and alpha glucosidase. So alpha glucosidase is a group of enzymes which cause the digestion of polysaccharides to monosaccharides. so acarbose, hoglibose, and miltitol. So by inhibiting the absorption, inhibiting the digestion, the absorption of glucose is inhibited. Then we can have the incretin mimetics. So the parenteral glucagon like peptide 1 receptor agonist we have already discussed. Then oral, this is semaglutide, and DPP4 inhibitors which inhibit the metabolism of incretins like sitagliptin, vildagliptin, saxagliptin, linagliptin, algogliptin. These are all oral incretin mimetics. Then finally we can have another group of drugs which inhibit the glucose reabsorption and are helpful in diabetic kidney. There are SGLT2 inhibitors, for example sorgliflozin, remogliflozin, dapagliflozin, ertugliflozin, empagliflozin, ipragliflozin, lusogliflozin, tofogliflozin, sotagliflozin, and canagliflozin. So this is all about